We were clearly explained the guidelines by Professor Madan. Lohit told us how to read the MRI scan. Now Rajan explained us how to do the biopsy. Now we take the biopsies now and we are taking it to Dr. Anila Kurian, who is going to tell us how the pathology is useful and what a urologist should know about the pathology of prostate cancer. Welcome, Anila.
I hope I'm audible to you.
Yes, Anila, loud and clear.
Yeah. Thank you so much, Dr. Ananda and the entire team. And it's a great honor and a privilege to be here. I prepared this talk with the very, very basics because I assume that the vast majority are going to be trainees in urology. So pathology for you must be just pink and blue. So I'll just guide you through a little bit of how we interpret or what are the guidelines that are required to interpret a prostate biopsy. So the topics to be addressed today, the basic, we cannot talk about prostate biopsy without mentioning the Gleason grade, the score, and now the prognostic grade group. Most of my talk would be on the latest recommendations of a biopsy reporting, that is by the International Society of Urological Pathology Consensus Conference, and which was published in 2020. This is the latest guidelines which we strictly follow. And a quick few points about what are the prognostic markers that you would want your pathologist to mention in a radical prostatectomy specimen. So the first thing is a Gleason grade, the score, and the prognostic group. These, for a urology resident, these terminologies should be very clear. You cannot interchange them or mix them up because that's going to create a lot of confusion. So just make sure when you start reading up about pathology of the prostate, these are the terminologies, the grade or the pattern. These two terms are used interchangeably and they represent what we see under the microscope. That is the architectural pattern. And we all know that there are 5 patterns, and based on the picture, we grade it or we give a particular pattern to the tumor. The score is the sum of 2 patterns, and we'll talk a little bit about how we come to the scoring. And this is the recent addition, the ISUP grade group, which is based on combining the grade, and we take into consideration the grade as well as the score, and you have 1 to 5 grade groups. So what's on the left was historically and been used as the Gleason scoring system for many, many years until 2015, where the new modified Gleason grade group came. And we know the reason behind this is because this grade group was done on TURP and radical prostatectomy specimens before the immunohistochemistry came into play, whereas now with more modalities and more imaging techniques and needle biopsies being the predominant pattern, they have been made some small modifications in the Gleason's pattern. And the one on the right is what we follow. We do not follow any of the older system at all. But most of it is the same, except for probably 3 and 4. Many of what was initially called pattern 3 have now moved as pattern 4. And also, if there is comedonecrosis, it straight away goes to pattern 5, irrespective of if it has a Cribriform pattern. So that's the main difference between the two. So I am not going into how to identify tumor and the morphology. I'm sure that the urology residents will be interested in this, and you could go to the Johns Hopkins University website where Dr. Epstein has a beautiful teaching module and quizzes at the end of it. And I think by the time you finish his slides, you will be quite well versed in interpreting the pathology. So Gleason's pattern 1 to 3 are all composed of very well-formed glands. The only difference between 1, 2, and 3 is how the margins are. So they're all single round glands. In pattern 1, it's tightly packed. In pattern 2, it's loose. And pattern 3 has an infiltrative border. That means it goes into the benign glands. Whereas pattern 2 and 1 are confined as a nodule. They stick out or stand away or stand apart from the benign glands, whereas 3 infiltrate the benign glands. That's the only difference between 1, 2, and 3. So that is important because now we do not report 1 and 2 on a needle biopsy for the fact that we cannot see the margins, the outlines. We cannot make out if it's confined or if it's infiltrating. So it should not be. And also pattern 1, now we found what originally was the Gleason pattern 1. Now vast majority of them, when you do an immunohistochemical stain for the basal cell markers, they all have basal cells. And by definition, a malignant tumor, a malignant gland should not have basal cells. So what was thought as grade Gleason score 1+1 is now mostly adenosis, which is a benign condition. Now coming to Gleason scores 3 and 4, it could be because of a variety of combinations. The ISUP guideline says you do not diagnose them on a needle biopsy. Very rarely, it may be diagnosed on a TURP or a radical prostatectomy specimen. Now coming to pattern 4, this pattern consists of either cribriform glands, poorly formed or fused glands, or even the glomeruloid glands. And pattern 5 has no gland pattern. There is no gland formation. The tumor cells are so poorly differentiated that they cannot form glands. So they appear as just sheets of cells or cords or strands of cells. And if you have comedonecrosis anywhere, you straight away grade it as a Gleason pattern 5. So that's the basics about the Gleason scoring system. So we do not use 1 or 2. And for a needle biopsy, it is only 3, 4, and 5 patterns that we are talking about. So now coming to the score, it's very simple. If you have only one pattern, you multiply it. So you add it up and you get a score, the score. Now, if you have 2 patterns, we take the predominant pattern. In this case, more than 50% was pattern 3 and the rest was 4. So it's straightforward, predominant and the second predominant pattern. Now, what happens if you have a vast majority, like if you have 98% of the tumor is pattern 3 and a very small 2% of the tumor is pattern 4, that's a higher pattern. In that case, you still consider the higher pattern because you always, it's a needle biopsy, and you saw in the previous talk, there's always a chance that the needle may have missed a larger tumor with a higher grade. So if you have any amount of higher grade in the tumor, in the needle biopsy, that has to be taken into consideration, even if it is less than 5%. So in this case, it is 3 + 4, 7/10. But the reverse is not true. Like if you have a predominantly pattern 4, say 97% of pattern 4, and just a very small area showing a pattern that is lower, you ignore the lower pattern because studies have proven that even though there's a pattern 3, for all practical purpose, this tumor is going to behave like a pattern 4 + 4, 8/10. So you ignore if it is less than, so the cutoff of 5% holds good in when you have a lower pattern. Now, what happens if you have more than 2 patterns? And that's not unusual because quite often we see 3 patterns in the biopsy. In that case, we use the predominant pattern and the highest pattern. It is not the next most predominant pattern. You ignore the second most predominant pattern and you go to the highest pattern. Now, if this was 4 and 5 and 3 was the less predominant pattern, it's straight away. It is 4 + 5. But in this case, even though 5 is the tertiary pattern or the least dominant, you include it because it's of a higher pattern. Now, that was about the needle biopsy. And this was from 2015, this was very clear in our guidelines. But in the 2015 guidelines, they were not very specific about how would you report a tertiary pattern on a radical prostatectomy specimen. They did not have a consensus, and it was sort of concluded that you use the predominant and the second predominant, and if there's a tertiary pattern, you could put a comment under your report saying that there is a tertiary pattern. But as clinicians, I know you may not read the entire report and you may not see the comment and you may not signify it, and you would just see 3 and 4 as the 2 predominant patterns, and you may use just that in quantifying or in estimating your prognostic markers. So in order to avoid overlooking the tertiary pattern, now they have the 2019 ISUP guidelines say they have given a cutoff. If it is 5% and above, you include it as just like in a needle biopsy. Like in this particular radical prostatectomy, the predominant pattern was 3, there was 4, and 3% was pattern 5. Because it's less than 5%, we ignore it and it falls into a grade group 2. Whereas this radical prostatectomy, there were 3 patterns, and pattern 5 was 7%. So by rule, we include that. So this tumor is now falling into a grade group 4. So the significance of very systematically looking for a tertiary pattern and quantifying falls on the pathologist, and I think more than the urologist, the pathologist should be aware about how significant this is, because from grade group 2, the patient is now straight away put into a grade group 4. So the importance of very diligent search in a radical prostatectomy specimen. So you're all aware of this, the 5 groups. My prediction is this group 4 is a little unstable here, for the fact that we all know a pattern 3 predominant with a little bit of 5 may not behave as just a pattern 4. So we can expect probably in the next revision of ISUP something happening in the grade group 4. But as of now, this is the system we follow. Now, if there's one particular slide I want to discuss, these are the 2 new things that the ISUP classification has brought about: presence of intraductal carcinoma and presence of cribriform glands. Now, intraductal carcinoma, the name itself says it. It is a tumor that is growing within the larger ducts and the acini. So normally what happens when you have a tumor, the tumor grows and it infiltrates the stroma. The smooth muscle stroma is what is getting infiltrated. But here, instead of breaking out and growing into the stroma, it grows as a tumor through retrograde through the large ducts. So that's an intraductal carcinoma. It is associated with a higher stage, and it is now considered an independent risk factor for progression-free and cancer-specific survival. So it's important for the pathologist to identify it and for the pathologist to report the presence of intraductal carcinoma. Usually, 95 or more % of time, intraductal carcinoma is associated with a typical adenocarcinoma, an invasive adenocarcinoma. In that case, we give a Gleason score of Gleason pattern 4 is considered as intraductal for intraductal. If there's comedonecrosis, it becomes a Gleason pattern 5. However, there are very rare case reports of a pure intraductal carcinoma. In the sense, the patient does not have any adenocarcinoma, all he has is tumor growing within the ducts. In that case, it's a very aggressive tumor, but Gleason system, scoring system is not applied to a pure intraductal. Just like in small cell carcinoma, we do not give a Gleason pattern, a pure intraductal also we do not give a Gleason pattern. But vast majority, it's not like that because it's associated with the SNR pattern. Now, the next most important thing is that's come into the limelight with 2019 classification is cribriform glands. We all know that the moment you say cribriform, it's pattern 4. But you need to know that cribriform alone is not the basic pattern in 4. You may have fused glands, poorly formed, and glomeruli. Among the 4, cribriform is associated as it is an independent predictor of poorer outcome. And now the recommendation is, if we have a pattern 4, we have to mention the percentage and we have to tell very clearly in the report whether a cribriform pattern is present in the biopsy or not. Now, in the previous talks, we heard about the systematic and the targeted biopsy. Here in Chennai, I would say 75% of the needle biopsies we get are combined systematic and targeted biopsies. We do get transperineal biopsies as well as transrectal biopsies. And transperineal biopsies, the cores may be 25, 30, even up to 40 cores we have reported. And our urologists give only 1 core in per vial. So if you have a 40 core biopsy, you will have 40 vials coming in, and we individually put them in 40 blocks. So at the end of it, you have 40 paraffin blocks and 40 cores to examine. But the other techniques that they follow are you clump together right and all the cores from the right and all the cores from the left. So it's up to the understanding. It's just make sure that you have a perfect understanding with your pathologist how you want the report. Do you want it as individual cores to be reported? In that case, it is better that you send each one separately, because more than 2 cores for practical purposes, if you put more than 2 cores or 3 cores into the vial, there's a chance of the cores getting fragmented. You may just do 2 cores and send it, but by the time the tissue travels and reaches the pathology lab, it may fragment and the report may say 4 cores. So, and the measurement may go wrong. So in order to avoid all the confusion, after having done such an elaborate procedure like a transperineal biopsy, you would want the most accurate report. And out of practical experience, it's my suggestion to you that you send an individual core in individual vials. So having said that, once we receive the cores, this is the ISUP recommendation of now how to report targeted as well as systematic biopsies. So if it's a core having both targeted and systematic, first report the targeted biopsies. So here is a core, a targeted biopsy, which has 4 cores, out of which 3 are positive. So you individually assess each of the cores. And in this target, you give just the aggregate score. You do not give individual scoring to each core. Instead, you study all the positive cores and give an aggregate result. In this particular case, it was 3 plus 4. The moment you have a pattern 4, you have to mention what % of pattern 4 it is, and also whether cribriform pattern of growth is present or not. Now, once you report the targeted area, then you look at the systematic biopsies, and based on right and left, you have to mention how many cores are there, how many are positive, and each positive core has to be individually given a Gleason score and individually quantified, and you should mention whether there is a cribriform pattern or not. So each core should be given equal importance in a systematic biopsy. You cannot clump it together.
Anila, you have 1 more minute.
Yeah, done.
Okay.
The needle biopsy, other recommendations that a clinician would want to know is sometimes we may see periprostatic fat in the biopsy and you may have tumor in it. So that should be mentioned, because then you can plan your radical prostatectomy, the wider margin accordingly. So sometimes the seminal vesicles may come in through the core. That should be mentioned. Lymphovascular and perineural invasion are the other things to be mentioned. And finally, just a slide on a radical prostatectomy specimen. We embed the entire prostate. We divide it into 4 quadrants from the apex to the base to the seminal vesicles. The whole prostate is embedded after inking them and labeling them. So these are the important independent prognostic markers, and just ensure that your biopsy report has all of them: the score, the group, the margin status, presence of extraprostatic extension, seminal vesicle, and lymph node positivity. And again, from my experience as a pathologist reporting for many urologists, what you're most interested after doing an elaborate surgery is the surgical margin. Now, nobody is happy to give a surgical margin positivity. Now, what happens? When do we get a margin as positive? One, which is very rare, it could be actually a technical, I wouldn't call it an error, it's a technical issue where the tumor has been cut through. That's very rare. Most of the time, a positive margin comes when the tumor has spread out, this extraprostatic extension. We know that the prostate does not have a capsule, so we do not use the word capsular extension. It's extraprostatic extension. And there's a limit to which you can do a resection, or it's going into the sphincter and you don't want to damage the sphincter. So in that case, you could get a positive margin. So here's the muscles of the sphincter and there's a tumor growing out. You cannot afford to take a further wider excision, so you get a positive margin. So this is the outline of the prostate. Extraprostatic soft tissue, tumor has grown wide, and the nature of the tumor is such that it's unavoidable for you to get a positive margin. So you should not be upset with the pathologist when we give a positive margin. So with that, I conclude. Thank you.
Thank you, Anila. And you clearly mentioned that if there is a positive margin, it's only a surgeon's fault, not a pathologist's fault.
No.
Thank you very much. Now, since Anila made